Glaucoma. Glaucoma is a pathological intraocular pressure which cause optic nerve change and visual field defect. And we talked about the definition in the previous video. Now in this video we will talk about the classification and of the glaucoma and one type of these types. Glaucoma is divided into primary and secondary types. Each of them contain two subtypes, open or closed subtypes. What is the difference between open glaucoma and closed glaucoma? The difference is so simple. By using gonioscopy, the gonioscopy will reveal the angle of the anterior chamber of the eye. If you see the angle, this is called open angle glaucoma. If you cannot see the angle, or you see this iris in this position in front of the angle, this is called closed angle glaucoma. What is the difference between primary and secondary types of glaucoma? The difference is the cause. Is that in a primary glaucoma there is no systemic pathology affecting the eye and no local pathology affecting the eye, but in the secondary type there is a systemic pathology like diabetes mellitus or steroid induced causing glaucoma, or it may be caused by a local pathology in the eye that cause glaucoma like blood close the angle, or inflammation like uveitis, or pigment dispersion syndrome, or pseudoexfoliation glaucoma, in which there is a deposition in the trabecular measure of material produced by the epithelium of the lens, iris, and ciliary body. We will focus on this video in primary angle closure glaucoma. Primary angle closure glaucoma has another name called acute congestive glaucoma. It is most commonly affecting female more than male, and the average age at presentation is 50 to 60 years. Most commonly affect Chinese, and it may be inherited as autosomal dominant or autosomal recessive, but most commonly is sporadic. Most commonly affecting the eye with the refractive error in the form of hypermetropes. What are the risk factors that causing primary closure angle glaucoma? We have a predisposing factor and precipitating factor. The predisposing factor are the factors that causing the disease to appear in this people or in this person but not in another person. They are, in case of primary angle closure glaucoma, is that people with small eyes like Chinese people, or people with hypermetropes, because hypermetropes eyes has a small eye. The small eye, the content of the small eye are more near to each other, and so the iris becomes more near to the cornea. Old hypometropic nervous menopause female. It affects the old age most commonly because in old age the iris becomes more thickened. When iris becomes more thickened, it becomes more near and more sticky to the periphery of the cornea. Hypermetrope, as we said, small eye, more crowding. Nervous menopause female means that in nervous menopause there is sympathetic overstimulation, and sympathetic overstimulation causes ciliary body congestion, and when ciliary body congested, it drops the iris to front of the cornea. The precipitating factors to the primary closure angle glaucoma is the mydriatic effect. The patient has been exposed to mydriasis effect. The mydriasis effect may be a mydriatic drugs like sympathomimetic drugs, or just prolonged exposed to dark color, because dark room color causing mydriasis, and we will illustrate it and explain the relationship between pupillary dilatation and this condition. The pathogenesis in normal persons, there is what we call it a relative physiological pupillary block, in which there is a minimal space between this iris and the lens to allow the aqueous humor to flow from the posterior chamber to the anterior chamber. But in pupillary dilatation content, the iris becomes more sticky to the lens, more close to the lens, and this minimal space will disappear. This causes that the aqueous humor accumulates in the posterior chamber of the eye. Accumulation of the aqueous humor in the posterior chamber of the eye will increase the pressure in the posterior chamber and causes pumping or bowing of this iris forward anteriorly, more closer to the cornea. Then it will end by adhesion between the iris and the cornea and closer of the angle of the anterior chamber of the eye. Closure of this angle prevents the drainage of aqueous humor from the anterior and posterior chamber, elevating the intraocular pressure inside the eye. So, what will happen if the intraocular pressure increase over the normal? Increasing in intraocular pressure will cause damage to the optic nerve and the retina by causing pressure on the blood vessels that supply them and causing ischemic effect to both optic nerve and the retina. But in condition like normotensive glaucoma, in which the intraocular pressure is not elevated but still pathological to the optic nerve and retina. What's the mechanism? It's thought that the optic nerve head in this patient is unusually susceptible to the intraocular pressure or has an intrinsically low blood supply, so minimal ischemic effect that has no effect in normal person will cause optic nerve damage in this susceptible patient. What is the clinical picture of the acute congestive glaucoma? We have 5 stages. The first stage is the prodromal stage, which means the intermittent stage characterized by transient attacks of headache, blurring of vision, and halos around the light. Is caused by patient when susceptible patient exposed to stimulating agent, moderating agent, either drug or prolonged staying in dark room will develop pupillary dilatation and the circle continue and the symptoms will develop. But it relieves by sleeping or exposure to bright light, because both of them causing meiosis and return the pupil to its normal position. Aqueous humor drainage will continue. If the patient comes in this stage, prodromal stage, how we can diagnose him? Because the attack is transient, it may come between the attack. First, from the history: headache, blurred vision, halos around the light, recurrent attack. This. Then we do propagation test to prove that the condition is a prodromal stage of acute angle closure glaucoma. What is the propagation test? Propagation test idea is to expose the patient to the same effects that cause the attack. So we give mydriatic drugs like sympathomimetic drugs, or expose the patient to dark light, in which he will develop meiosis and he will develop mydriasis. And we will measure the pressure difference before the test and after the test. If the pressure difference is more than 8 millimeter mercury, it is a diagnostic. What is the treatment of this stage? In this stage, the treatment is by doing surgery, iridotomy, surgical iridotomy. Surgical iridotomy idea is that when we apply another pathway here to the aqueous humor to follow from posterior chamber to the anterior chamber. So if he develops another attack of pupillary dilatation and closure of this pathway, there is another pathway here and no aqueous humor accumulation will occurs, and no an increase in intraocular pressure. The second or the other stage is called acute attack or acute congestive stage, in which there is no relieving of the attack. The headache will become more severe and marked decrease in vision and rainbows around the light. What are the signs that I will see in this condition? I will see that the cornea becomes cloudy and becomes edema. Due to rupture of the basal epithelia of the cornea, the aqueous humor will enter the cornea, consist of water vacuoles. These water vacuoles act as a prism that bifurcate the light. So the patient will see a rainbows around the light. Iris will appears as a bumpy iris, and the anterior chamber will become more shallow. Also aqueous humor enter the lens and cause glaucoma flecans. Glaucoma flecans means that there is water in the lens, and if we see the fundus, it will be a hygromic fundus. But the most important sign in this condition is the pupil, to see the pupil. Normally, a normal person, the pupil is reactive and regular and round in shape. But in patient with primary closed-angle glaucoma, the pupil becomes semi-dilated and irreactive and vertically oval. The explanation of this, that there is a decrease in blood supply to both muscles of the iris, the dilator pupillae and constrictor pupillae muscle, so the pupil becomes not full dilated and not myotic in semi-dilated position, fixed or semi-dilated position, and also irreactive. If we introduce a light to the pupil, it will not become a myotic, because there is no activity of the constrictor pupillary muscle. It also oval in shape, vertically oval in shape, because the muscle of the dilator pupillae muscle has a radial fibers. The horizontal fibers are with less blood supply, and the vertical fibers has more blood supply. If all the muscle exposed to ischemic effect, the horizontal muscles will be more affected, and the vertical muscles will preserve some tone, so the pupil will appear oval, vertically oval in shape. The treatment of the acute stage is either the posterior or the peripheral anterior synechia has been formed or not. Peripheral anterior synechia is the adhesion between the iris and the periphery of the cornea. If it has been formed, there is no role for ioidectomy. So the treatment of choice is to do external fistulization operation. But if it hasn't been formed, do ioidectomy and create another pathway to aqueous humor to follow through. The third stage is the chronic stage, in which the patient becomes late. With the acute stage, he becomes late, and the posterior and the peripheral anterior synechia has been already formed. So the patient condition has no role for ioidectomy. The treatment of choice in this condition is to do external fistulization operation. The absolute glaucoma. Absolute glaucoma is the end stage of primary angle closed glaucoma, characterized by painful blind eye. The pressure is so high, and the vision is markedly decreased. In chronic stage, the vision, there is a perception of light, but in absolute glaucoma, complete blindness occurs. In this condition, the treatment is to do what? Is to do external fistulization operation to decrease the intraocular pressure, and do what we called it inoculation to remove the eye. The treatment, as we said, in each stage, the treatment consists of medical treatment and surgical treatment. Medical treatment, we use it before the operation to decrease the intraocular pressure before we do operation. Because if we do operation for a patient with increase in intraocular pressure, it will cause hemorrhage inside the eye. Sudden drop of intraocular pressure cause hemorrhage inside the eye. So we use a medical treatment for 24 hours to decrease this high pressure. The treatment we use the local drugs and systemic drugs. The local drugs which we use like bilocarbine. Bilocarbine is parasympathomimetic muscarinic agonist, causes miosis. And we use also carbonic anhydrase inhibitor, dorzolamide, and beta blocker, all of them used as eye drops, local effect. But we use also a systemic drugs like carbonic anhydrase inhibitor, dorzolamide, 1 tab each 6 hours to decrease the aqueous humor formation. We also use dehydrating agent like mannitol 25%, 1 gram per kg, used with caution in patient with kidney or heart failure, because mannitol effect is that to increase the osmotic pressure inside the blood, so the fluid inside the spaces of the body will drain to the blood. The another option is the surgical treatment. As we said, we can use peripheral iridectomy. Peripheral iridectomy is used in condition when there is no formation of the peripheral anterior syncytia. If the peripheral anterior syncytia has been formed, we do external fistulizing operation. In condition like absolute glaucoma, the last option is to do inoculation of the eye. I hope that I help you in understanding the topic. Good luck.